Hello, my name is Paulin Jirkof. I'm a 3R coordinator at the University of Zurich, and my research interest lies in the field of refining pain management and pain assessment in laboratory mice. And this is what I'm going to talk about today. I'm going to do that in a very simple and basic way. And if you are an expert for veterinary analgesia or something, it might be a little bit basic to you, but I think because we have a lot of potential in refining pain treatment of these very small laboratory species, I think it makes sense to start at the very beginning. And it makes sense because unfortunately there are many reports and reviews that state an underuse of analgesia in small animal treatment, not just in laboratory animal medicine, but also in small pet animal practice. Obviously, you will find many comments of experts like, for example, Paul Flagnell, who really report an underuse of analgesics in the field of mouse treatment. And additionally, you will find systematic reviews, and this is just one example by Larry Carboni. For example, you find systematic reviews that show that analgesia is either not used regularly in small animals or it is underreported. Here, for example, a systematic review of articles that report of pain for procedures. And you see, we do have a reporting of analgesia of about 10 to at max 65, 70%. And from my experience performing systematic reviews on analgesia in certain procedures and models, I can tell you that I assume that 60 to 70% is really on the good side. In many fields, analgesia reporting is very bad. And that's a problem because we do not know what is the status quo in analgesia use in small rodents. And we do not know also how good the data is that has been achieved or that has been yielded with these kind of studies, because we know that pain and analgesia has a huge impact on experimental readout, and therefore this is actually information you should know when you want to assess or evaluate a scientific study. So this is why I'm going to talk about basic refinements or simple refinements in pain management. I like to highlight here that pain management is, of course, no refinement, right? Pain management is a must. It's a scientific and ethical must. But of course, there are easy ways to find better pain management protocols or to refine existing pain management protocols. And I'm going to do that today in 7 steps. So these are my 7 steps. Other people might have another approach, but I think one of the most important steps is to accept that there is no gold standard. Different individuals may react differently towards drug treatment. This might be due to different strains and lines, the age, the sex of an animal, and also, of course, the health status, which has a huge impact. And therefore, we have to acknowledge that there is no one-size-fits-all gold approach toward analgesia, towards pain treatment. And therefore, we have to treat every individual animal as a patient, as a tiny patient, but as a patient, which we would do also with larger animals and with humans, of course. And there are different ways to approach these. One is maybe the platter approach from veterinary medicine, but you will find other structured way to approach this. The important thing is that you do approach it and really try to improve and not just use what you have always used, because that might already be outdated by now. So step number 2, very important, what can be expected? So what kind of pain do you expect? How painful is your disease? How painful is your procedure? Is this inflammatory, neuropathic pain? Is this severe pain or not? How long is it lasting? How is the course of the pain? All these things you have to know to decide on an analgesic substance. And additionally, of course, as I said before, there are certain characteristics of the patient that might affect how a drug is acting. So line, age, sex, health status, and so on and so on. And because we are talking about animal experimentation, you also should find an analgesia that has no side effects on your readout or acceptable and controllable side effects. That is not trivial, but it's super important. We have some challenges. First of all, there's not a lot of published studies on that really publish clinical relevant literature. So we are missing PK studies for mice very often. We might not know what is the duration of clinical relevant action, what is the clinical relevant effective dose of a certain drug. We of course have PK studies, pharmacokinetic studies, right? But very often with very exotic dosages or very exotic administration routes, so not that useful for the standard use. Same is maybe true for PD studies, pharmacodynamics. And also in the past we had the problem that we were missing sensitive pain indicators for mice. This is changing at the moment, and therefore do not rely on what you did all the time, right? I check the recent publication, check expert recommendations. There are a lot of revisions of recommendations at the moment. If you don't find that, you might have to do pilot experiments, but you will find a lot of very useful literature, maybe even a publication on your specific model, not only describing how to assess pain, but also how to treat it maybe. And there are also these expert informations of different societies that can be very useful in deciding on all these important things that you need to know when you want to plan an analgesia protocol. When you know what can be expected, you know which analgesic substance can be used, because this steers it somehow, right? I'm not going into detail and describe different substance classes here. Of course, it makes a huge difference which type of pain you have, and you will decide on very different pain substances if you have more severe or less severe pain. But to give you a little bit of an example, I choose Buprenorphine because it's very often used, and I personally work a lot with it. So to describe some of the challenges and the preconditions that we have to consider. Starting with Buprenorphine, it has a quite strong or relatively strong analgesia, which is a pro. So it's an opioid centrally acting. Of course, I wouldn't use Buprenorphine as a single analgesia with very strong pain because it's just not potent enough for that. But for many, many pain states, it's very useful. It has a quite lasting effect of, let us say, 8 hours, which is nice because most opioids act very short, and you can apply it in very different ways. It has some side effects because it's an opioid, obstipation and some behavioral side effects. I will go into detail in a few minutes. You might have a slight immunomodulation, but actually that's a pro, right? Because with most opioids you will have quite some immunomodulation, so that's already nice. We know relatively good what you have to inject, for example, and to have an effective analgesia with Buprenorphine, but it's still quite a range, right? It's 0.05 to 0.1 in mice. I wouldn't go below 0.05. I don't think that is enough in mice. But we know, but this is quite okay already. We have huge ranges of dosages for other analgesics. So Buprenorphine really is one of the best known analgesic substances in mice, or the best described one. For others, we are not that safe. We are not that secure. We do not know what actually is the best dose. And you might know that there is a discussion on caprophane, for example. At the moment, and the dosage recommendations are really different, or are differing a lot between different authors. So that's already a plus again for Buprenorphine. You have, as I said, certain side effects that are typical for this drug, and this is something you have to know. And you should know this also for other drugs if you use them. And I just brought here some, right? This is, for example, for Buprenorphine, a reduction of food intake and therefore maybe a reduction in body weight, which could be related to constipation or nausea. Mice cannot vomit, so what they show is they either will not eat anymore or they will show pickle behavior, which is something we know from rats a lot. So eating of non-eatable substances can be really life-threatening in a rat. In mice, not that much, but can be observed also. And then we have side effects like you see it here. We have here a normal mouse during the day, so naive, sleeping most of the time, and then during the night it's active most of the time. And if you inject Temgesic 3 times during 24 hours, for example, it looks like this. So a lot of activity, we call it hyperlocomotion. And if you have a very high dose here, for example, a sustained release formulation, you might have even more activity. That could be harmless, but it could be a problem if you are into behavior or circadian rhythm and you cannot wait long enough after your surgery for your assessment. Other typical side effects are these strobe tails or these tiptoe gait, like hyperlocomotion, something that I would expect quite normal, wouldn't worry me too much. But keep in mind other side effects that could be a warning sign, like sedation, because that should not happen actually in most mouse strains. So these are things you have to know if you want to use an analgesic, but some of these side effects might be totally acceptable. But if you have now decided on a substance, I would highly recommend not to decide just on one. Sometimes it's the only way to go, but if you can use a multimodal approach, I would do that. That would be the approach you would choose in a larger animal. That would be the approach you would choose in a human. Multimodal approaches, that means you might use different classes of analgesics and maybe even different sites of administration. And the principle behind this is to have complementary pharmacokinetics and also complementary mechanisms of actions, and ideally that would result in a synergistic effect, and it has the result of a maximization of effect, so more pain or better pain relief or longer pain relief, and a minimization of side effects, because you might need lower dosages of the single substances for this. And there are different ways to achieve a multimodal protocol, and one important is, of course, the combination of systemic drugs and local anesthetics. Unfortunately, also very rarely used in small rodents at the moment, but it really has an advantage because it really reduces the need for systemic pain relief a lot. Step number 5, the administration route. So the most easiest way, or the easiest way, is always to go orally, right? So just offer something and the animal ingests it. Voluntary. That would mean no stress for you and no stress for the animals. If you don't use gavage, that would be not a voluntary oral intake then, of course. But you have to keep in mind, if you go orally, there are some issues you have to calculate, and one could be it might not be completely controllable, but that totally depends on how you do it. We will talk about that later. But you might have problems with solubility, compatibility, and very often bioavailability. So bioavailability is lower in oral intake very often, and you have to calculate that, of course, to have still a pain relief. If you go systemic, that is more controllable, of course, depending on the method. It goes, of course, with restraint and injection, which could be stressful, but at least you have a safe intake. So whatever you want to do, you have to balance, right? If you have severe pain, you will for sure not go orally only, right? You probably need a systemic approach. You have to inject something. But if you have more mild pain, you have to balance the stress of the restraint and the injection against the secure pain relief, and maybe you come to the conclusion that in some cases and voluntary oral intake is fine and is something that can really refine your animal experiment, and I will give you some examples of this in a few minutes. When should you apply? Yeah, as early as possible. So we would call that preemptive or preventive analgesia. So treat before any kind of pain occurs. And then how often do you need to apply? Again, that has something to do with the route and with the substance. Keep in mind, very frequent application can lead to stress and maybe induce even pain in the animal if you have to restrain and freshly operate the animal. Therefore, some opioids might not be very useful because they are only acting less than an hour or a few hours. Others, like buprenorphine, might be okay to inject because they act for 8 hours. If you have a non-steroidal anti-inflammatory drug, you might have the luxury to inject only every 12 hours because they are very often longer acting. And here is an example, as I said, buprenorphine. Again, we would normally target a dose of 0.5 nanogram per milliliter in the serum to expect a clinically relevant concentration in the organism. What you see here is the injection of temgesic, so buprenorphine, once in green or maybe 2 times in blue, and then you see the serum concentration, and what you see is, well, after 4 to 6 hours, it might be okay, but after 8 hours, we already are quite below the serum target concentration. Therefore, we would expect that buprenorphine acts around 8 hours, but not longer. Therefore, you have to inject frequently, maybe even more often than 8 hours. That's, of course, not ideal. I will come to this later. You could now argue, well, this is a centrally acting opioid, so am I really interested in the serum concentration? Well, I can, of course, also offer you the brain concentration of buprenorphine. That's another study from our lab. What you see here is a comparison of a depot formulation of buprenorphine and a normal non-retarded formulation, temgesic. And you see, yes, after 12 hours, we still have in both formulations quite high serum so concentrations, in this case not in the serum but in the brain, that should hint towards effectiveness of this drug. But of course you cannot rely just on the concentration in a certain tissue. So what you see here now is an analgesiometric test, and you saw here 12 hours, and here again you see 12 hours, and you see that in an analgesiometric test we do not see anymore a significant difference between the temgesic and the control group, which is in this case just nasal, so saline injected animals. So we cannot be sure that after this kind of brain concentration really indicates a clinically relevant and effective dose. So we still stick to the 8 hours until proven otherwise. So I think you are also quite okay with 8 hours. That's probably a very safe guess. But how to refine that, right? I already mentioned sustained release and depot formulations, because this is, of course, a very nice approach to get rid of these frequent administrations, right? So a continuous and stress-free or stress-reduced administration would be very nice. This can be done with osmotic pumps, but that's an invasive approach, of course. Solvent injectable systems containing the drugs, that might be a way to go. And what I mean are sustained release formulations or depot formulation or retard formulation. So you inject once and then you might have an analgesia for 2 to 3 days, maybe 1 day, depends on the formulation. If you are from the US and you're watching this talk from the US, you are lucky because you can buy these kind of sustained release formulations. If you are from anywhere else in the world, you probably cannot, which is really a pity because this is a very, very good refinement and a very important refinement approach. But you saw in my slides before, it is possible to get depot formulations of buprenorphine if you do them or if you prepare them yourselves. And we did this in our studies in the past, and we could do it because we have a collaborator who has a lot of pharmaceutical expertise and also the equipment that is needed. So if you have that in your organization, in your lab, that's fine. You might do it by yourself. If not, you probably have to rely on other approaches, and a very typical approach is to use so-called uncontrolled voluntary intake protocols. These here are single drinking events of mice during the day and during the dark. And this already shows us the problem. This might be true for drinking water. It's probably very comparable to food pellets, might be even true for Medigel or other substances that you might mix with analgesia. And that is that animals just do, while they do ingest water, for example, very frequently and very often during the dark phase. During the bright phase, this is very infrequent. So this is something you cannot rely on when there is substantial pain. Therefore, this is not to be recommended when there's more than mild pain. So when you want to use this, you probably have to inject at least during the daytime. There are alternatives to this uncontrolled intake. They have some advantages and some disadvantages, but I like to show them to you because I think they are super useful especially for mild pain and maybe as an add-on to a systemic approach, for a kind of multimodal approach maybe. And these are controlled voluntary intake protocols. This here, for example, is an approach where you just drop the substance mixed with, in this case, it's honey, directly into the mouth of an animal. This is an antiparasitic drug in this case, but you can, of course, do that also with an analgesic. Of course, this still needs a little bit of restraint, but you can do better. And this is another example. So controlled voluntary intake via jelly, so a sterile jelly mixed with a substance that you want to have the animal ingest. That is like the one before, totally controllable, because you see that there was an intake at a certain time, and you see if it was a complete or maybe just a partial intake, and then you could still react and give, for example, a rescue analgesia if needed. So this protocol here, you find the video in a protocol exchange server. This video shows an intake completely without any interaction. This could be also Medigel, this could be also Nutella or peanut butter or whatever the animals like to eat. This here is an example from the EPFL. I'll show you the video shortly. It's of course a rat or a mouse. This is a rat that has been trained to ingest something that is mixed with something that the rat really likes. What you see here is really a controlled intake, so you know how much went into the animal at a certain time point. You can be sure everything is in. You saw it's no stress for the people involved, it's no stress for the animal. It might be even rewarding for the animal because we have to be honest, they are quite bored with their normal food, so if they get something additional, it's like a reward, something that could be even considered to be a refinement. So if your substance administration works like this, of course, that's perfect. Now you could say, well, this is a rat, right? We are talking here about mice, and rats are so easy that you can train them, they get tame, and so on and so on. That's not possible with a mouse. Well, I can tell you, well, it is. It's possible with a Black 6 mouse, right? So that's here a voluntary intake protocol based on condensed milk in a black 6. The animals are trained for 3 days, so meaning three training sessions. This is already day 3. It works because this is a pipette, right? This works because condensed milk is something they just favor. So if you find something that fits with your substance, this is a very nice approach, a very nice refinement approach to get something into an animal without having restrained stress and so on. Okay, step number 6, nearly finished now. I think these administration protocols have a huge potential for refinement, and you should think about what you can do. But what at least has the same potential for refinement at the moment, I think, are non-pharmacological measures also, because there's so many things you can do to make it easier, to make it less burdensome for the animal. One could be, for example, using less invasive techniques and so on. I really like to highlight aseptic technique also, which is also super important for rodent surgery to get rid of any kind of subclinical infections and so on, or any kind of problems during recovery. I also highly recommend warming, and I do not mean just warming during surgery, but also after surgery, also for quite some time. So why not, if you have a warming cabinet, warm your animals for 24 hours after surgery. In our experience, in very severe models, this can reduce mortality, but also in less severe models, it can really reduce the time to recovery, to full recovery. Use soft food, use fluid therapy whenever possible. There is really no need to feed an animal that underwent craniotomy with normal pellets, right? You can use high caloric recovery food also for other models, of course, and this can really make it easier for the animal. Use soft bedding, use more nest building material because this helps them to keep warm. Use a social and familiar environment. That means get them back to their group as soon as possible, and use gentle handling techniques. Cupping or tunnel handling should anyhow be used, if you ask me, as a standard, but at least in freshly operated animals do use these techniques. There's really no need to pick up a freshly operated mouse by the tail if not needed. Tunnel cup handling really makes it easier for you and for the animals. And then my last slide today. I don't think there is a good pain treatment protocol without a good pain assessment protocol. The experience of the same procedure may differ in different individuals. You might differ in your performance of the procedure. Therefore, it might be more painful one time than the other time. The drug treatment might fail or might differ, and every time there might be unexpected pain that could occur. So use these, if you have these very specific pain signs, maybe for abdominal pain, use them. If you maybe you want to use a more general one like the Morse Grimmel scale, that's useful. Sometimes it can be useful to observe also natural behaviors like nest building or social behavior or boring behavior. And with this, I'm going to sum up. Well, analgesia and pain assessment is an ethical and scientific must. There are very good reasons to take care of these. it's not that trivial all the time. Sometimes it can be quite tricky, especially if you want to adjust that to a very specific experimental setup or readout, and therefore, why not try to get the help of an expert in veterinary analgesia? To my knowledge, most of these experts I have met, at least those that I have met, are quite nice people, so I think they will be very happy to help you. Keep in mind, there is no gold standard. You need to estimate the expected pain in your individual patient. Then you can choose an adequate analgesic substance. Ideally, this shouldn't be monoanalgesia, but multimodal analgesia. Try to refine your administration protocol. It should still be secure, but if you can use a less stressful protocol, then go for it. And whenever possible, apply non-pharmacological measures that can be a refinement, and then assess the efficiency of your protocol and then start again, right? If you see something is wrong, you have to start again and change your protocol maybe. Okay, with this, I'm finished. If you have any questions left, if something is unclear, feel free to drop me an email or use the question and answer box here in this system. Yeah, I hope you enjoyed. Bye-bye.